I'm going to be talking about early encounters and experiences of nurses with the imminently dying. So that's the last few hours of days of life. I conducted this work with a colleague of mine, Professor Jan Draper, here in the UK. So for us, end-of-life care policy has been a real priority on the political agendas, both in the UK and internationally, and has been identified by the World Health Organization. It's also been subject to a lot of debate in academia and also in terms of practices globally as well. And healthcare policy has consistently highlighted deficiencies in quality of end-of-life healthcare, and certainly in the UK, the media has really highlighted this as well. So it's really been at the forefront for us in terms of practice. So in response to this, and even previously, there have been a range of strategies, such as the end-of-life care strategy, that's been implemented across disciplines and settings. So for example, not just in hospitals, but in the community, within care homes and hospices, in a way to improve the experience of care for patients and their families. So what we know is that nurses are at the forefront of this care. They're caring for not only dying patients, but actually managing the dead body, performing last offices and rites, and dealing with the corporeal, so the institutional aspects of death and dying, as well as the emotional, how it affects them and also families, and the relational dimensions of death. So those relationships they have with patients and families, but also those with their colleagues as well. So while nurses might be taught the theory and practice of end-of-life care, little is known really about their early professional or prior experiences of and reactions to death, and how then these shape their understandings and influence their practice. So why do we want to explore nurses and student nurses' experiences with the imminent dying? Because it's not just this review that we conducted, but we also went on to conduct some interviews with student nurses. And the reason that this piqued our interest is not that we just necessarily come from an end-of-life care, palliative care, and death and dying background. It's kind of educationalists as well. We wanted to find ways in which we could be informed in terms of our teaching. And so we therefore considered the UK and international literature as well. So this review set out to identify gaps in research, and it could use Oxley and O'Malley's 5-stage process conducting a scope and review. Well, there's 5 main themes that were identified, and this, the first related to different philosophies of care. We've already heard about the kind of dissonance between wanting to provide care versus cure, and the way we're sort of kind of subject to that. Another theme concerned relationships, so that's with patients, their families, but also with colleagues. Another theme related to knowledge, the level of knowledge and how prepared people were, the impact of the death and what that meant physiologically and emotionally for nurses and student nurses, and also giving care, what that was about and what that felt like. And there are also, as you'd imagine, organisational factors such as mentoring and support, as well as team working and professional relationships, which really had a key here. So we identified 23 papers from the international literature. This review has been published, so if people want a copy, that's fine. They can get in contact, and I'm happy to kind of supply that, because then that will give a breakdown of the kind of methodological process that we undertook. But for the purposes here today, I just kind of want to get on with the findings, the kind of juicy bits, if you like. Okay, so in terms of attitude to death, nurses' commitment to deliver such care reflects on their own attitudes towards death and dying and looking after dead body, which can be established really early on in their career. So they're kind of newly qualified, they're kind of eager to get out there, and then they're sort of coming across death and dying. And these early encounters can have a lasting effect in all sorts of ways. I'm not just talking emotionally, but about the way that they care for, for the dying in future. And also the issue to do with post-mortem care as well, because these can be particular sources of distress and stress for not only nurses, but also for students. And this can, all of these factors combined, can often lead to what Cooper and Barnett call death anxiety. So this is where, physiologically and emotionally, we can become really anxious about death. Therefore, we tend to avoid it. We might go off and do other tasks around kind of the care and the kind of emotional aspects of kind of caring for the people who are dying and their families. So we know that end-of-life care, there's a lot of complex factors involved, but students as well as nurses, particularly in the UK, are expected to deliver such care, and particularly during COVID-19, their kind of roles changed. And when we conducted interviews, this kind of changed that whole way of kind of learning on the job, which is, you know, really interesting. But what we know from previous work is that students and some nurses prior to the kind of coming on board are unlikely to have encountered death and dying professionally. They might have had experience maybe with family members, etc., and that might have prepared them a little bit, but not necessarily in a hospital environment. So confronting that the first time, and particularly the dead body, can be a real stressor. And I can remember in my kind of professional life, coming across the dead body for the first time, and I kind of cared for people, it was a real eye-opener for me, and it wasn't something I felt very prepared for. So I can really get that sense of what the literature is saying, what nursing students are saying in our research as well. And so there can be all sorts of impacts on this, including the psychological of performing last offices, which I'll get onto in a minute. So, of course, one of the themes that came up was knowledge, and this essentially centres around being prepared, because the literature is saying that nurse knowledge of end-of-life care and palliative care is relatively poor. So people feel really unprepared to deliver end-of-life care, even though they really want to provide a really good quality care. So, for example, Anderson et al., they conducted a study in New Zealand on nurses' earliest memorable death, and they reported on a lack of skills and knowledge about death and dying. And there was a real sense of frustration that they kind of gave over into the interviews because they felt it influenced their ability to deliver some top-notch care, which is so important at the end of life. And again, in another study in Cooper and Barnett, students really caught between wanting to do the best with the patient, but within the limitations of her role and knowledge. And one of the examples of this was where somebody was working with a dying patient and their families, and there were a lot of questions being asked, like, you know, what can we expect next, or, you know, so on and so forth. So they were kind of having to cope with a barrage of questions, but they didn't have a knowledge because that knowledge wasn't shared by other members of the team to that particular person. So they're really caught in a very difficult position. So this idea of being caught between doing the best and those limitations really kind of encapsulate by that example, I think. But another study by Grubb and Arthur also pointed out that when students are at a later point of their study, they tend to kind of have more positive attitudes to death and dying. Okay, so then coming to another theme, such as the impact of death. What I've come across before as well, so I wasn't kind of surprised to see this in the literature, is when we kind of talk to nurses and student nurses and we ask them to kind of recount their early experiences, they remember it really vividly as though it happened yesterday, and the symptoms that they experienced, you know, physiological anxiety, whether they felt quite sick to the stomach or they had knots in their stomachs, you know, and then sort of a real kind of presence of fear. Particularly around attending to the corpse, etc. Because I think the other thing to do with that is a cultural thing, certainly in the UK, is that we're not necessarily, stuff has become more and more hidden. We're not necessarily exposed to that, where, you know, go back a sort of century ago, you know, it was our job as family members to attend to the dead body, so forth, and everybody had a particular role. So that's something that's, you know, not surprisingly, people are unprepared for, particularly changes in the body. You know, we'll get discoloration, the rapid changes, and also having to pack orifices as well. So the impact would be sickness, the kind of willingness to care or not, maybe an emotional distancing, finding other nursing related work to undertake, and then a focus more on the physical needs of the patients, maybe, you know, tying them up in the bed, etc., and not the emotional, like how they're doing and how they're facing the end of their life, which is so kind of critical for people. A lot of these experiences as well were mitigated by what was considered to be good and bad deaths. So good deaths were those which were considered to be, you know, they were expected. There was a high level of awareness by relatives, so they were around, you know, they were knowledgeable about this, and there was an absence of distressing symptoms. So they were symptoms that were well managed. So there was pain control and things like that. Other good deaths were those which, from the findings, which had to do with limiting disruption to the ward routine. So, you know, we have meal times, etc., night shifts, and so forth. And nurses felt that a good death came about when they prevented the dying patient from, you know, sort of dying alone. Bad deaths were those that were considered to be where nurses had very limited control of the events. They were quite sudden, out of context. They might have been moved from an intensive care ward to another ward, and all of a sudden they kind of, they died, etc. A bad death is also where there was poor pain control, or the do not resuscitate orders weren't actually carried out despite the patient's wishes. And there was also those deaths which resulted in like kind of conflict between what nurses perceived should happen and what doctors perceived would happen. So that different philosophy of care versus cure, a lot of that was going on and sort of come out. So again, these kind of studies do point out that there is a real desire to want to deliver high quality end of life care, but there's barriers. There's a bit echoey there. Is that better?
Yes,
yeah.
I do.
So there's a real tension between trying to balance the two different
aspects.
I can hear somebody else.
Okay, maybe I should have tried recording my own too.
Someone else talking in the back.
Yeah, there's is somebody muted because I can hear.
Please, could you please, please, could you please mute?
I'll find out whether they can. Because I can hear
conversations.
Go ahead.
Ah, there we go. Is that better? Fantastic. Okay, right. So again, so there's this balance as well, not just in terms of wanting to deliver high quality end of life care, but all those barriers in place. There's also balance, which everybody faces kind of in this profession, is being close to patients, so you provide that real good emotional care, but also maintain that professional distance. And everybody has different ideas of what that means, because some families appreciate, if you have some emotional investment and you display some emotionality, whereas others think, well, you really shouldn't be doing that. And some nurses felt compelled to change their occupation as a result, not necessarily, nursing as an entirety, but maybe moving from sort of palliative care to other kind of sections. So I kind of intimated before, like some of the physiological responses that nurses experience. So I've got one quote here where somebody said that, their stomach tightens, therefore I get pains, I lose my appetite, and I get a lump in my chest. So these are quite strong physiological reactions, and really important to kind of highlight this here, that it's, that's kind of coming out. So again, treatment, which might have been seen as invasive by nurses, really kind of conflicted with them ethically and morally about what should go on. And they obviously don't always get to make those decisions because of where they are in the hierarchy. There's a real kind of dilemma for them. A lot of nurses early on in their career obviously are enthusiastic, they have certain expectations, but this really kind of jarred with the reality that they faced. A couple of studies have expressed disappointment or feelings of failure when this wasn't possible. A sense of dissatisfaction and inadequacy when the care provided was perceived by nurses to be related to staff shortages. So I've already said that, nurses perceived a good death as ensuring that somebody didn't die alone, and in the absence of relatives and things like that, particularly when they live hundreds of miles away and they can't be there at that certain time. If a nurse can't be there due to staff shortages, then that kind of really grates on the sense of well-being as well. And that whole kind of sense of a lack of time of being with the patient to complete all the care that they felt really needed to kind of happen. Okay, so the kind of different philosophies of care, so what I talked about, the kind of care versus cure. So an Australian study of 121 nurses, there was a real kind of conflict of care where it's perceived that aggressive intervention just induced suffering amongst patients. For example, one nurse said the doctors keep pushing, I think they push for another day, for more aggressive management. And so there's this real sense of powerlessness felt by some nurses about when their kind of intimate knowledge of the patient, they've gotten to know the patient, they've talked to them, maybe met the family, etc. Which is a shame, because sometimes I do feel that work is meaningless when they, invested that kind of time and that energy in that care. And similarly, an Australian study of patients with end-stage heart failure again showed there was tensions between the cardiac, the kind of cure versus comfort palliative care teams, with one promoting life-sustaining treatment and the other one thinking that, you know, they kind of failed the patient because they used to kind of providing pain control, comfort care, etc. And in this regard, nurses would then have the task of having to initiate communication between across these different teams. So you can imagine the challenge in having to do that, and being that advocate. And some find that the most frustrating and time-consuming aspect of their role. So when we think about pre and post-registration training and end-of-life care, so this is before people have qualified and then people have become qualified, their inadequacies have been identified in those particular curriculum. And there's an obvious need for further education, palliative and end-of-life care, particularly I feel around preparing nurses for first encounters, those initial forays, to recognise the imminent signs of death, to be emotionally prepared, to know how to break bad news, communicate effectively, and to really kind of get to grips with that kind of ethical reasoning and conflict management, because it's assumed that better education will decrease anxiety and increase positive coping, but the jury's out on that one. A lot more work needs to be done here. So as educationalists, as somebody myself who was involved in this, you know, we do have a duty to explore other means of support to enable students to cope more effectively. We can consider simulation, drama, effective integration of theory and practice, reflection, which is a key part of what we expect nurses to do, and cinema education. Others are positive that use of cadavers would be an idea. And others have also suggested to give students the opportunity to talk about the emotional aspects of death and dying. And also importantly, to have positive role models and clinical supervision. So it's about trying to create opportunities for students to experience death in a stress-free environment. So that's away from the hospital, the community setting, and into the classroom, into those simulation rooms. Excuse me. So not to encounter death for the first time in all its busyness in a hospital setting in the presence of some very distressed relatives. And it's assumed this will enhance preparation and reduce fear. And of course, we can't sort of mention any of this without mentorship and support. And this is a really key thing, because the support that colleagues can provide, senior managers, you know, there can be some really excellent, good role models out there. And when I've sort of worked with doctors in previous research projects as well, and they've talked about how sometimes they can remember those early days when they had senior managers and they were excellent, good role models, and it's carried them throughout their career in terms of working in end-of-life care. So it's so critical, because the lack of support mechanisms can lead to isolation and then an inability to support others. And nurses feel vulnerable as senior colleagues don't understand the emotional impact. You know, they develop that relationship with the patient, and when nurses are part of a team, and if they're able to discuss the patient or not, because when they do, it does enhance their ability to cope. And that's important because we want nurses to be able to cope so that we can retain them to do that brilliant work they can do with families. And this has really become apparent so much during kind of COVID-19. So to sum up, nurses do emphasise that it's privileged to be caring for dying patients, but the knowledge of palliative care, particularly in the early stages, is lacking. There is a lack of education and training, and consequently, nurses do feel unprepared to deliver, you know, that key quality end-of-life care. So how can we help prepare students for registered nursing? Education should focus on recognising the signs of imminent death, emotional preparation, positive role models and mentors. And while studies suggest that such training can reduce death anxiety, there has been a lack of empirical research demonstrating the effectiveness. Okay, next one. The student nurses and experienced nursing staff are impacted both positively. Sorry, I do apologise all the time. Support helps to shape a more positive attitude, leading to provision of high quality care. A lack of support associated with death anxiety and death avoidance. We've got to be mindful of emotional contagion, distress, and even burnout. And education as a senior nursing managers, we do have responsibility to make sure all of these things in place. Staff do need to be fully informed, and that includes student nurses as well, communicated with and supported to prepare themselves, the patient, and their families of imminent death. And I'd like just to kind of leave you on a note from the Royal College of Nurses, because often we kind of sometimes drag out the negative aspects of kind of caring for death and dying at the end of life. And what they're saying is, although challenging and emotional, and which can be demanding, when you are supported and you have the right skills, knowledge and attitude, end-of-life care can be very rewarding. And a key part of the nurse's role is being able to come alongside the person who's dying and those close to them and support them through for what is essentially a natural process. Thank you. Thank you so much for listening. Really appreciate it.
Thank you so much. Thank you for your valuable